very first thing we're doing, which we're doing today, is to get genetic material extracted from the virus in the hands of public health labs in the various state jurisdictions, so they've got a positive control for their laboratory tests. We've got a sheet of human cells, virus growing in it very evenly across it, and then the next thing we do is to then ampule up the virus itself.
In this screencast, we will cover the CT findings of COVID-19, the disease associated with the new coronavirus. I want to give special thanks to Adam Bernheim for providing multiple cases of confirmed COVID-19 pneumonia. At the end of this screencast, you should be able to identify and describe the spectrum of findings in viral pneumonia and explain a basic algorithm for managing patients with suspected viral pneumonia in the radiology department. First thing I want to say is that the findings are not specific to COVID-19. I will show you cases of COVID-19 and suspected COVID-19, but these cases have a pattern on CT that's consistent with acute lung injury or organizing pneumonia. And there is a broad differential diagnosis that includes multiple different types of viral pneumonia, some atypical bacterial pneumonias, drug-induced acute lung injury, and also cryptogenic organizing pneumonia, which is an idiopathic form of primary organizing pneumonia. Because the findings are nonspecific, clinical context is key. Most of the patients presenting with COVID-19 have a fever as one of their first symptoms. And then the other symptoms that are often seen are shortness of breath, cough, and fatigue. Interestingly, most cases are not presenting with rhinorrhea or a runny nose. Now let's talk about the CT findings associated with viral pneumonia. Early in the disease process, the pattern seen on CT tends to be dominated by bilateral peripheral ground glass opacities. These ground glass opacities tend to have a rounded morphology, but are not necessarily nodules with well-defined margins. Consolidation can be superimposed on the ground glass opacities, but earlier cases have a lower incidence of consolidation and tend to be ground glass predominant. Again, discrete nodules are not being reported, so well-defined nodules are not being reported. Pleural effusions are not characteristic of the disease, and lymphadenopathy is not characteristic. As the disease progresses, the ground glass opacification tends to become more confluent. It often remains peripheral, but it can become more diffuse throughout the lung. Crazy paving is being reported, which is actually a pattern within the ground glass opacification where there's also septal line thickening that creates the look of stone pavers. Later in the disease, consolidation is more commonly reported, and that consolidation is often superimposed on the areas of ground glass opacification. There's also a report of linear opacities developing later in the disease process, and those linear opacities being associated with architectural distortion. And within the areas of opacification, we can see bronchiolar dilation that may not be present in the spared parts of the lung. Let's talk a little bit about what ground glass means. So I have an example of ground glass in the center of the image here, and that is the kind of glass that is often used for glass stoppers. It's often seen on slides in pathology. And what you can think of ground glass as being as incomplete alveolar filling. And that incomplete alveolar filling increases the density of the lung and makes the lung look somewhat white on CT. We can compare this lung that has diffuse ground glass opacity to this normal lung, and you can see the increased density due to partial alveolar filling. This is not a case of COVID-19. This is diffuse ground glass opacification related to a different process. Now let's look at consolidation. Here we have a normal lung, nice and black with the vessels and the airways easily seen. And over here we have a lung with diffuse consolidation. This is a person with ARDS, or acute respiratory distress syndrome, and that consolidation is complete alveolar filling. That's why it looks more dense than the ground glass opacities, and you also start to see the airways within the opacities as air bronchograms, and you no longer see distinct vessels within the area of consolidation. And that is sort of a graphical representation of complete alveolar filling or consolidation. This is the ground glass opacity compared to consolidation. Notice you can see the vessels within the ground glass opacities, and we don't have air bronchograms. All right, so let's get to some cases of COVID-19. Here we have a case care of Adam Bernheim at Mount Sinai showing early ground glass opacities. These are small, ill-defined ground glass opacities with a rounded configuration. Here we have a patient presenting with fever and respiratory symptoms who had a flu negative and traditional viral panel negative PCR and is therefore under investigation for COVID-19 infection. And we can see these ill-defined ground glass opacities with a rounded morphology in the periphery of the left upper lobe. In addition to traditional ground glass opacities with a rounded morphology, at times people are reporting with COVID-19 and other viral pneumonias a more dense round opacity. This is progressing from ground glass opacification really to more of a focal consolidation, but you can see it remains peripheral and poorly defined. This is another patient under investigation, and in this case we can see these ground glass opacities in the periphery of the lung, which are starting to become confluent. So you could imagine that maybe there were 2 or 3 nodules here, and now those nodules have increased in size, creating a confluent peripheral ground glass opacity. When you see the ground glass opacities with superimposed consolidation, we can see here in a patient under investigation, an area of peripheral ground glass opacification with a more focal area of consolidation superimposed on the ground glass opacification. This is a case of confirmed COVID-19 where the patient has this peripheral area of consolidation, although there do remain some areas of ground glass opacification within the more consolidative airspace opacities. In more progressed or severe cases of COVID-19, you may see diffuse ground glass opacification with areas of consolidation. So in this case, the process is still predominantly peripheral. It's ground glass predominant, diffuse lung disease with areas of developing consolidation. This is another case of severe COVID pneumonia, and in this case we start to see more of that architectural distortion. So it almost looks like the lung is tethered or being pulled, and we start to see these more linear opacities in addition to the areas of consolidation and ground glass opacification. Another finding that's being reported is bronchiolar dilation in the region of pulmonary abnormality. So we have these areas of ground glass opacity that are peripheral and starting to have superimposed consolidation. And notice the bronchi within these regions of airspace opacification are dilated and more prominent than in the part of the lung that does not have ground glass or consolidation. Again, bronchiolar dilation in the regions of pulmonary abnormality. This is again a case of severe confirmed COVID-19 pneumonia. This is a nice example of the linear opacities that are sometimes reported. This patient had ground glass predominant disease, but if you look in the right middle lobe here, you can start to see some linear opacities. These linear opacities spread throughout the lung are associated with some ground glass opacity and some consolidation. And we can also see bronchiolar dilation. So you see these dilated bronchioles in the area, or bronchi, in the area of abnormality. So you get bronchial dilation or bronchiolar dilation in the areas of abnormality. Again, a case of confirmed COVID-19 that's relatively severe, but notice predominantly we have peripheral, patchy ground glass opacification with some areas of developing consolidation.
Just in a few seconds, we will get a visual demonstration, if you want, in multiple dimensions.
好，可以写了啊，可以写了，给他开一个。1个小时以后去登记审查结果。
放大一点。
这个人是有问题是吗？这怎么看出来呢？
非常有大量的模糊力。
我们这样一天能做多少个这样的 CT？
我们刚刚高估计的时候大概是150左右，现在进行分区管理之后，我们现在病人量大概是100左右。
100左右。
大概100左右，对。
好，可以睡下来，睡下来。
Now let's see how these pictures are analyzed by the doctors.
对，这样看。
That's
拿到影音里面之间的有不同的密度、不同的形态，那么伴随真相不同，它就疾病不同。像这个，你看这个新冠肺，这个就它在这几个层面的膜玻璃影很淡很淡，这是早期，早期也这种不能漏掉。但是 CT 如果说胸片看得出来了，这个人就不好救了。他到
很明显了，是吧？
对，他才晚期了。对，好，这个这都很懂了哦。对，它最后都变成两肺全部变白，它都是里面那个蛋白渗出，把肺泡填满，然后不能呼吸，人都会去世的。看你难度，我们判断上，我们不看是我们。
所以您现在是在做什么
？12月16号。
我在看的。
对，在中心医院。
正常的应该是什么样的？
正常应该是黑色的。
正常应该完全是黑色的，是吗？
灰色和这个条索是血管。
These doctors have been working around the clock. Some of them have been home for over a month.